It is basically on the complications. And so whether our patients are going to tolerate this triplet therapy or not. So you like to make any comment, anyone from the audience have personal experience, they can come on.
Can I make a comment, sir, regarding the cost?
Yeah.
So in India, cost is not a major concern. If you want to combine abiraterone, docetaxel, and triple drug therapy using abiraterone and docetaxel is financially not challenging for a patient at all, because both drugs are generic in India, so it's very, very cheap.
Yeah, Sudhir, please.
Yes, sir. I think I'll agree with Dr. Banyal. It's not very costly whether we have generic for both the drugs. Only thing that we generally do not advocate at all in low volume disease. Whatever the evidences are for high volume disease, but that too patient has to, he has to have very good performance status. Personally, I do not advocate much about triplet therapy, because with chemo, the quality of life goes down. But then most of the medical oncologists, they do suggest our patient when they go for a recommendation, and then I send my patient to Vineet.
So can I make a quick comment?
Jagdish.
I'm a medical oncologist by profession, and I do not profess triplet for all patients at all. It's for that one odd patient who's reasonably fit and has a very high volume metastatic disease burden, and you're worried that he'll end up with a bad cord compression or a visceral disease. So in those patients, I think there is definitely a role.
But what was the survival in that group of patients, what you are talking? If somebody already have a paralysis or something?
No, sir, not paralysis. Impending cord compression, there is a 2-year OS benefit by giving these patients. So it's a significantly better disease control if you have young, fit patients with impending visceral crisis.
Yeah, Jagdish.
Sorry.
Sir, in bladder tumors, we have the chemosensitivity of the tumor is now predicted. Now, like preoperatively, we used to do chemotherapy in advance. We know that molecular classification has come. And likewise, now with the double treatment intensification with the doublet or triplet, before that, do we have anything to predict that this is going to be a chemosensitive tumor in prostate? Where do we stand now? Because I have seen that earlier, like after we started the Stampede trial around came, everyone has started. Now it is like there is no that between the metastatic disease, hormone refractory disease, and the hormone sensitive. It is narrowing down. Straight away you are hitting the patient with a doublet or triplet. Is there anything to say, and on a molecular basis, this patient is going to respond for the chemotherapy in advance?
You want me to take that question, madam, or would you want to speak? No, so there isn't. I think we're comparing chalk and cheese here.
Correct,
when we're talking about neoadjuvant chemotherapy in bladder, we're
Yeah.
looking for a pathological response. You're dealing with a metastatic de novo disease. And let me reiterate, all of us do not give chemotherapy to all patients who walk into our clinics. Yes, we identify patients that we feel will definitely benefit with them. But yeah, to answer your question shortly, there isn't one specific test which can define who's going to benefit with chemotherapy and who probably isn't.
Jagdish, you like to make?
I've got one question. Actually, a lot of patients have a fatty liver, and we are worried about their hepatic problems, abiraterone. Do you think we can reduce the dose of abiraterone, add another thing, or how can we do that?
So not addressed scientifically, but again, abiraterone is actually, you can reduce the dose if you increase the fat content of the diet. So, but yeah, add cheese, that's the point, and not the jam. Actually, jam will also do the trick here.
Sir, I
Dr. Salam, yeah.
I wonder, we are trying to push all the treatment which were really few years back were indicated for the CRPC patients, and we are pushing it towards the high volume metastatic disease and leaving the CRPC patient unattended. What are the treatment of the CRPC then?
Oh, rather it's the other way around, sir. We are trying to delay CRPC in the first period. We want them to live longer, and we want the CRPC to happen 3 years later.
Sir, you have shown it very clearly in your slides that after certain time, after 60 months, even with darolutamide, Aracin trial, the patient will pass into the state of CRPC.
Yeah. So, sir, we hope...
You're delaying, not curing actually.
Absolutely. Metastatic diseases, as we speak, are incurable. But if I have 10 years to live, I would want to live 8 years as HSPC and 2 years as CRPC, because the other way around is probably not going to happen. If I get a 1 year of HSPC, I'm probably not going to live for 9 years as a CRPC patient. That's most likely to happen.
We need your final comments.
Olaparib and
Salam, you want to say something else? Yeah.
Yes, I would like to emphasize on the fact that the olaparib or rucaparib at the same time, lutetium is going to play a very significant role.
Lutetium-based therapy. Yeah. We need your comments, and then we'll give to
one last question now.
Yeah.
Well, that was a good debate. See, on one side you have the doublets versus the triplets, where you have overall survival benefit of about 11 to 13 months over a doublet. But the criticism for the triplet was that there was no abiraterone alone arm. So had that been there, because that is a standard of care on its own when you compare it with ADT. So that was one criticism which was, it was not there. Probably that would have shifted, or clarified the doubts to a large extent.
Agree, sir. I think that was it's one of the criticisms of that trial.
Thank you.
Madam, would you want
No,
to
sir.
comment?
Time is over.
And I think that's the key point, really, is that the trials haven't addressed the question directly, which is why we're having a debate. But, yeah.
Thank you.
Okay, thank you, both the speakers, and highly selected cases, individual patients, you can think of triplet. Otherwise, we can continue with the doublet at the moment. Thank you.
For the next debate on increasing use of laser for TURBT is beneficial, we have in favor Dr. Mujibur Rahman, who is Professor and Head, Institute of Nephrourology, Yenepoa Medical College, Mangalore. And over to you, sir. You have 7 minutes for your presentation.
The topic for the debate today is increasing use of lasers in TURBT. It's a surgical topic. At the outset, I would like to say that I am not for a debate with my good friend, but over the period of 20 years, what I have had the experience of treating the NMIBC, I would like to share my views on that. And the laser, the improvement in laser and increasing use of lasers is not an isolated technical advancement. It is a parallel with the instrumentation, with the narrow instruments have come, and the optics, then the view, once you enter into the bladder, the view inside the bladder, and other parallel developments that have happened. And especially when the narrow tubes have come, especially the flexible ureteroscopes and all. And CA bladder is one tumor where repeatedly you are scoping inside, and the urethra, structural diseases are very high. And the flexible ureteroscopy, which is 6 French or 7.5 French, through that laser can be used. And bladder cancer as a whole, it's a challenging and most expensive tumor in GU onco. And 75% are NMIBC, and TURBT with intravesical treatment with immuno or chemotherapy is the treatment of choice. And none of the guidelines, they won't say that it's an optimal TURBT is required for NMIBC, non-muscle invasive. AUA tells, EAU tells, and CN guidelines tell. But what is the aim of doing a optimal TURBT? It is the grading has to be done. As Madam said, Anita Borges in the previous talk, she said 73, 2004, 2016, 2023. All these, the grading, still there is a confusion among the experts. They say that G1, G2, G3, or low grade, high grade, still they have not. And when you go to the RCTs of single center RCTs, the biases are very common, that they have not defined the disease, where it is, whether the 73 WHO grading system can be used, or 2004, 2016, 23. There are biases. Another thing is that the architectural pattern of the tumor. You must have seen that you go inside, you see the tumor, either the location wise, once you distance the bladder, the location is different. And once the configuration of the tumor, again, is different. And the laterality and experience of the surgeon in a single institute. What I have done in 2003, when I do it now, it is different. So the experience of the quality of resection, everything matters whenever you see a single center RCT. So meta-analysis is taken as of the RCTs is taken as an evidence. And detrusor muscle for staging and complete removal is mandatory. And without mentioning on my increasing use of these lasers, without mentioning the instruments, I can't go. From the NITS to the flexible ureteroscopy of 2001. Because in the pediatric tumors, this is most often ignored, as well as the structural urethra. If you don't have a small scope, you cannot go, and laser is the only treatment in those kind of cases. Then conventional TURBT, I'm not going to the depth of it. What I believe is, seeing is believing, and feeling is the truth, as the British man, he stated once. So this is one of the disadvantages of the monopolar or the bipolar TURBT. What you do is, it's the bleeding. I am not against the TURBT. It is one of the best, and I prefer that also, especially more than 3 centimeter stones, 3 centimeter tumors, and anterior wall tumors near the bladder neck and all, you will have to use it. But still, the bleeding you see in mono or bipolar TURBT. And the operator jerk, you can see that this bleeding might be, but once the bladder is fully distended, and you can see the external iliac veins and the arteries are near to that, and once the operator jerk comes, sometimes immediately you'll have to stop it. You cannot complete the procedure. Upgrading of the tumor can happen, and massive bleeding, catheterization time, everything increases. This is the meta-analysis of the RCTs, and bipolar TURBT could not replace the monopolar TURBT as a safer and effective in NMIBC treatment. Another one is safety and efficacy of bipolar versus monopolar TURBT, a systematic review and meta-analysis. That equal incidence of bladder perforations, need for transfusion, similar hemoglobin fall, thermal artifacts, and even though it's slightly lower than that, but both bipolar and monopolar TURBTs have. Another thing is, once you have distended the bladder, this bladder pressure is more than the venous pressure, and the circulating tumors, they have done a good study, the circulating tumor cell, but it has not affected the recurrence or progression of the disease in the long evaluation. Then next comes the en bloc resection of the bladder tumor, the incision of the urothelium and progressive dissection within the muscularis propria with a 5 millimeter margin, and tumor detachment with a bladder wall margin as a single specimen, and the retrieval, as everyone knows that if it's a small tumor, it's easy to retrieve. Otherwise, you will have to go to the next debater who is going to be like, you will have to do a piecemeal, but not much of a high bladder pressure is there, where you will get, there is a dissemination of the tumor cells outside. The guidelines again, AU and AU has further stressed that en bloc resection recommends performing both the techniques for NMI, strong rating, and in patients under consideration of the bladder preserving surgeries, maximal debulking of the transurethral resection of the bladder tumor, and assessment multifocal disease. AU also says the same thing. But en bloc resection of the bladder tumor reduce the under resection and understaging, and minimal surgical complications, and avoid dissemination of the malignancy. But for large tumors, 3 to 5 centimeter is not practically possible. Anterior wall tumors, again, is then a limitation. Broad-based tumors and bladder neck tumors, it is difficult to go for a en bloc dissection. And energy modalities for en bloc bladder tumor resection is the monopolar, bipolar, or hybrid knife, and lasers. And coming to the hybrid knife, I'll just go through that for the interest of the people. Then this is...
Sir, you have exactly 10 seconds left.
Then I'll rush through that. Then lasers, but the other fellow will be taking only 6 minutes. He has given me extra 2 minutes. Then lasers, light amplification by simulated emitter radiations. And first in 1966 in dog bladders they started, and it was the pulse dye lasers initially. And lasers have that, everyone knows that this will have, it has a monochromatic energy source is there, there's an active medium and solid liquid gas, and whichever it defines is the frequency and the wavelength. And it absorbs the light and the heat and vaporization and the scattering and transmission and those kind. And what all the lasers available right now, there is the Nd:YAG, HOYAG laser, and thulium YAG, green light, and other lasers. And the setting also is very important when you do a en bloc dissection. And the advantage of the lasers is the TA tumors, and you can go for a fulguration. And if you have the pediatric tumors also, you can resect it. And other things, re-resection also is possible. Restaging TURBTs is possible. And HOYAG laser, now it is the laser fiber, thulium fiber laser is coming. Instead of that fiber, inside is the fiber inside the console, and you have a pumped diode laser along with that, and this is connected outside, and it has got more of a precision. This is the in thing now in the en bloc resection. Little to no carbonization, precise incision, etc. This all matters, the staging of the tumor, tangential excision, because you know that the tumor won't grow uniformly. It will be in the laminar propria and anamysis. It is not directly going. When you cut it tangentially, the staging, the grading, staging, everything affects, which will later on will affect the treatment. And electrosurgery and lasers, you can see that the blood clot here. This is the laser resection. You have a clean resection near the ureteric orifice. You can, and the tumor. There's one study they say that in the near the ureteric orifice, we put a stent. There is a tumor dissemination, and they have seen that some of the ureteric tumors, upper tract tumors coming.
So you need to come to your concluding slide, please.
In conclusion, there is no operator nerve jet, that better hemostasis, post-op irrigation, recurrent rates, minimal charging, tumor near the ureteric orifice can be done, and more precise tissue cutting, no need to stop the blood thinners, anesthesia even under local and daycare, small caliber flexible instruments. And these are all the studies, evidences, these are all the like RCTs of the, meta-analysis of the RCTs, not the RCTs per se. Then one more thing I would like to show is...
Sir, I'm sorry you run out of time. I cannot allow you that. I am so sorry
and
for that.
This is confocal microendoscopy. This is for the preoperative and confocal laser endomicroscopy. And one more slide, madam. No, I won't take. This is being an academic...
You're taking Dr. Tarun's time.
That has concentric tube technology. This will be a robotic technology where you can see that this small concentric tube will be put into the urethra, and through this you can probe, you can put the probes inside. This you can go for an en bloc resection, or you can go for a laser resection, and this is the second trial, X5 pig model has come, now the human trials are going on. See this, in the pig you can go for a laser resection or with this thing, and you can suture also, and this is coming in the radical prostatectomy, transurethral radical prostatectomy, and other bladder tumor resection.
Sir, we need to stop now.
Yeah, thank you, madam.
Thank you, Dr. Mujibur Rahman. May I invite Dr. Tarun Jindal. Dr. Jindal, I think you have committed to only 5 minutes now, so you get 5 minutes.
As if the pressure of having a duel with Dr. Mujibur was not enough, now I am under duress